quite well, and now it's a time to remove it, which is far more crucial and usually neglected. So you need to have a proper dialogue with the surgeons. Suppose if the child is going to be discharged at 48 hours, we need to be stopping infusions at least 5 to 6 hours before that. Before that, we need to be making sure that the child is managed well for pain relief without the epidural catheter or the perineural catheter. So see to it that the analgesic regime is quite tight. Keep it off, tighten the regime, see to it that the child is at least 3 to 4 and 10 on 10 of VAS, and then remove the catheter, they're free to go home. Complications can be lingering motor block, nausea, vomiting, problems due to untrained personnel, especially in private small setups. Ensure the route of drug administration. I have had issues with epidurals being put to IVs, and I told myself that I probably should not be keeping epidural catheters in places where they are not trained to use epidural catheters. So the structural intervention is this way, that we go case by case, and accordingly we adopt post-operative pain management to each child using a multimodal approach consisting of surgery-specific analgesia with weight-appropriate dose of whichever drugs we are more used to. Role of the parents cannot be neglected. Let them go home and let them keep in touch with you, and the byproduct is you give them your phone number and then they know you, and they will say thank you. Thank you so much.
Thank you, madam, for the.
Well, we are very closely associated in pediatric circles with all our international, and I have been visited to his hospital. He was the person who was the pioneer in starting the microscope tubes. But I'm going to, in this topic, I'm going to talk about both the balance. We need to balance the things out. So, I'm going to talk about advantage and disadvantage of the cuff tubes and engaging uncuffed tubes. So this is how about the, does anybody use a cuff tube in pediatric patients? Okay, micro cuff tubes? So just I'm going to talk about now since last 50 years or 60 years we have been using in pediatric patients cuff tube. Almost there are a lot of variation changes happen into the clinical practice, and people were using started to be used a cuff tube in the pediatric patients. Yeah, started, but there were a lot of disadvantages of the cuff tubes which happened, and then the evolution has changed, and the variations changes has happened into the cuff tubes. So this is about, let's see what we can do. The uncuffed tube, what happens? So this is an example where I'm going to talk about. This is the 4-month-old child. What is the ideal size of the tube what we can use? A 4-month-old child is almost around 3.5 or 4, which is the commonly what we use. So just what is the, see, this is the uncuffed tubes are usually what we call as a plastic tubes, because they were what I say that it's really damages it because and a good paper by Dr. Holsky, who supposedly did a good study on how the cuff tube and uncuffed tube which has caused trauma to the laryngeal tubes, and if you see those pictures, it will be a really, you will see what, because they can lead to the severe complications of subglottic stenosis, and then the resection has been required. So my suggestions in this topic is that always remember, use appropriate size of the tubes whenever you are using the pediatric patient. So this is how, what happens when you are using an uncuffed tube. For example, in a 4-month-old child, if you're using a 3-number size tube, if you see that there will be a lot of leak will be there. And what will happen then, the ventilation will not be an effective. If you try to use a bigger sized intrathecal tube, uncuffed tube, then you can see how it fits into the laryngeal inlet, and it can cause the injury. So appropriate size of the tube which is used is 3.5, but in spite of that, since you can see there is a lot of minute leak will be there into the thing. So this link, which we need to have a good effective ventilation, which is always possible, it is always possible by the cuff tube. So this is what we follow into the adult practice. Cuff tube is the tracheal sealing. The same thing principle which is followed into the pediatric patient is the tracheal sealing. If same child I'm using a cuff tube of size 3, you can see exactly the cuff is linked like the aluminum foil paper which wraps around, properly fit into the laryngeal inlet. So this is how to think. If you use uncuffed tubes, you can see the same size cuff tube, you see a lot of leak. This link, what we know as a tracheal sealing, is always possible with only cuff tubes. So this is about the microcuff tube. If you see from the study which has shown that it appropriately fits into the appropriate size of the cuff tube with the outer diameter of the tube with the inner diameter of the trachea exactly fits into the. If you see these lines, the solid lines which tells that the exactly fits wrapped into the tracheal mucosal lining. So this is how the things is. So initially how it started, so the Dr. Kine, he was the first person started thought about to use a pediatric cuff tube into the butt. There were a lot of things which happened in that era where the initial cuff tube which were made of PVC, which has caused a lot of injury to the pediatric patient. So, but that has initiated the thinking process into the anesthesiologist where, oh, okay, this is what, if we change the material of the tube, which help definitely well. And this was the landmark paper into the pediatric anesthesia where we thought about doing the good cuff endotracheal tubes about, and initially they used were good things and these appropriate size, but since the cuff were not appropriate, sometimes I am going to show you the pictures where how uncuffed tube can cause the trauma. So coming to the microcuff tube, see, if you see, it seals at a very low pressure, so almost around the tens. And the study which shows that this is the glass tube, this is the microcuff tube which has been inflated, and the dye was injected. You can see in the lower end nothing is being inserted. With the PVC or this thing, you can see a little bit of dry. In this era where we think about the microaspirations, we talk about a lot of things, so we should know about that, what can help. So in that situation, we thought about which tube need, even a minute leak is not acceptable in this era. So this microcuff tube has been beneficial, where you can say absolutely there is no leak into the, so there are very minimal less chances of the aspiration into the patients. So as I spoke about, it seals at very low pressure, that is almost 10 centimeter, or if you say 10 centimeter of water, is the mean cuff pressures. And this was the study which was done by Andreas Gerber and Demarcus, which they further carried out the situation about how they. Then if you see the tube size, is that the correct anatomical dimensions, which is that it appropriately fits into the exact limit of the trachea. Why I am talking about this is because this is when you are using the cuff endotracheal tube in the head, head and neck cases where there is a lot of manipulation is there. In that situation, yeah, so there is a lot of margin in the carina. So it doesn't touch the carina because it helps to the manipulations is very minimal, and the trauma which can cause is very, very less. So this is how the endoscopic picture where you can see there is clear-cut depth marking. Why I am talking about the depth marking? Because it helps you in a difficult situation and difficult intubation where you know that okay, you have reached the laryngeal inlet, and you can see a clearly depth marking helps you to facilitate the intubation. And so there are a lot of studies which has an appropriate intubation depth mark, which has helped, and then the tube displacement I was talking previously about how we can help into the the head and neck surgery. So this is the study which was done. As appropriate fits a relevant age group. So what happened? There are a lot of exchange rate with the uncuffed tube happen. This is what the problem happens with the uncuffed tube. So again, you try to, oh, this is a very big size tube. I need to. So for example, in a 4-year or 4-month-old child, you try to fit into the 4 number size. You try to insert it. It doesn't cause a trauma. So multiple exchange rate with the uncuffed tube is much more higher than the cuff tube, because you know that if you inflate the cuff, exchange rate. So the exchange rate is almost around if you see in 500 patients, it is only 98% you will see the fit rate which can happen. So this is how often. So what you will say that is there any appropriate formula what we can choose the size of the tube? Yes, we have the same formula what we use, Motoyama or Cole's formula. Again, it is applicable into the pediatric patients. Yes, we can use a finger or little finger tip formula. It is applicable into the cuff tubes, and age-based formulas are practical. And then, but what happens with this is that a lot of time you get miscalculate and you use oversized tube. But into the micro cuff tube, it has been made so simplified. Just look at the back of the cover and you will see, okay, this is the size, okay, 3 size can be used more than 3 kg and less than 8 months. So very simple to think about and you can use. So there is no need to bother about how we should go ahead and the size. No need to remember the size of the tube. Just see on the envelope and you can use the tube. And after almost like 15 years the study was going on, and then in 2000 there was a good news in 2009. Dr. Andreas Gerber, he invented this tube, was known as a microcuff tube, which is the manufacturing company is Kimberly Clark, and nowadays they changed the name to the Hilliard. So this is what the multi-central trial study. Even in India, we have done the studies about the cuff tube in various medical colleges where we insisted to do studies, and a lot of topics were given to our PG students also, and came to conclusion that microcuff tubes are better tubes for the pediatric patients. And this was the result what was then, and we have seen this. As I was talking about, not all cuff tubes are better. If you see the size, so this is the tracheal lining, they are the laryngeal inlet. Initially, a lot of cuff tubes were made. If you see the cuff was on the laryngeal inlet where it can cause to vocal cords. So this various size tubes which has, this was like in a 5-year-old child, and the appropriate 5.5 size tube was used. So tube size where like the shaft was too big, they were touching the carina, even the slightest movement used to cause a lot of trauma too. So not all cuff tubes are the good one. So this is how I just want to say about the cuff tubes. And one thing is important in our life is that always we need a BP cuff measure. If you are doing a cardiac cases, then you have a lot of multiple invasive monitoring. So in that we can have a small thing when you are using a cuff tubes is that this is emphasizing into on this is that always when you are using a cuff tube, it is mandatory to use a cuff pressure manometer. Otherwise, it can cause a lot of problems, because sometimes what happens is when we are using a nitrous, it can inflate. It can cause the overpressure exertion onto the tracheal mucosal lining, and then it can cause a trauma. So this is what, so excessive cuff pressure must be avoided, and for that we need to use a cuff pressure control. It's mandatory. Which is like there are 2 devices. We can use a continuous pressure monitoring, or sometimes usually we have this one where we use intermittently. You can just monitor, or you can just attach this cuff. Even this manual cuff pressure can be attached, and continuously you can monitor, because you can just see on the pointer which can vary. You can see if you think that it is getting overexerted, you can just there is a wall which you can just deflate it and make sure that the continuous pressure monitoring is done throughout when you are using a cuff. There are a lot of advantages of cough tube, which is tube exchange is very precise and constant ventilation. There are certain situations, for example, now in our ICUs and ICUs, when we have a ARDS patients, or even in when you are giving an anesthesia to ARDS patients, sometimes you require, in that situation, you require a very precise ventilation. Otherwise, patient will desaturate very fast. In that situation, we have cough tube. In the situation when you are using doing a cleft lip and palate surgery, cough tube will definitely help you. That will avoid you using the throat packs into the thing. And uniform and control mucosal pressure, which is you can see with this thing. And apart from this, when we are talking about the greenhouse effect nowadays, OT pollution.